Let's do it.
Go ahead.
Okay. Good morning. Welcome, everyone, to our March 2026 AIDS Clinical Conference. We have our 2026 CROI update today with three excellent speakers. The first is going to be Dr. Raaka Kumbhakar, an assistant professor at UW. Second, Dr. Jehan Budak, who is an associate professor at UW. And third, Dr. Jimmy Ma, who's an assistant professor at UW. So thank you all so much for bringing this info to us. Just one more thing before I hand it over to you, Raaka. Please, folks, put any questions you have in the Q&A box, and we will do those at the end after all three sessions, but please put them in as we go along and you're thinking of them. So thank you all so much for being here, and Raaka, over to you.
Thank you so much, Julie. I will go ahead and share and ask you to tell me if it's in the wrong view.
It looks great.
Perfect. All right. Thank you so much, everybody. I know this will be a little bit of a whirlwind because there's so many of us, but we'll do our best to get you up to date. So I am starting with updates from CROI and HIV and STI prevention. I have no disclosures, but my objectives today, I'm going to review some updates in on-demand versus daily oral PrEP. Then we'll move to updates in injectable lenacapavir as PrEP. We'll discuss some investigational long-acting PrEP agents, and then finally we'll end in gonococcal vaccination. So starting with oral PrEP daily versus on-demand. One of the oral abstracts presented were the final results from ANRS Prevenir. So this was a cohort in France and really in the Paris region of around 3,000 men who have sex with men and others who were at risk for HIV acquisition from 2017 to 2025. And this group compared daily versus oral on-demand TDF-FTC for PrEP. The regimen was interestingly chosen by the patients, but switches were allowed. And when we looked at the results, the participants were majority MSM. They were born in France mostly, but I will note that some weren't, and we'll go back to that. And 47% chose the on-demand dosing regimen. Now, one thing that I think is really interesting to think about who chose what. So the percent using each regimen stayed roughly the same throughout the study, but 59% who started on daily switched at least once to on-demand, and 52% switched the other way. So that number remained about the same on who was on each, but who was doing that switched considerably. What about HIV incidents? So what you can see in this breakdown between daily PrEP users, on-demand PrEP users, and switch PrEP users was that the overall HIV incidence in the cohort was very low, so only 13 cases. Most new infection did occur numerically in those who discontinued PrEP. And you can also see numerically that the highest cases occurred in the on-demand group, but this was not statistically significant, and this wasn't a randomized study. And so there really was no significant difference in incidence of HIV between oral PrEP modality. And just going back to that second bullet, of the 13 cases, 9 of the cases had discontinued PrEP, and the remaining 4 had suboptimal adherence. This was some interesting data that the group presented about what was the impact of rolling out this PrEP program in Ile-de-France, so in this region around Paris. So kind of disappointingly, overall, there was a minimal decrease in new diagnosis of HIV. But when they broke this down between MSM born in France and those born abroad, you can see that there was a significant decrease in incident HIV and MSM born in France, and a significant increase in those born abroad. So in those two different sections on the graph. In addition, there were high rates of bacterial STI, mostly chlamydia and gonorrhea, and also a significant number of incident hepatitis C infection. But overall, PrEP in both cases was well tolerated. There was a higher discontinuation rate in the on-demand group, mostly due to GI side effects. So what are our oral PrEP takeaways? Both oral daily and on-demand PrEP remain highly effective options for HIV prevention if they are taken. In terms of what modality to use and choice, there's a high degree of dynamism of choice of methodology. The overall percentages in each group remained fairly static, so suggesting that at least in this population, people may move back and forth between those groups pretty frequently. And we still need to consider specific populations in PrEP reach, or there will be little impact on the overall epidemic. So I thought this was a really nice example of you can roll this out to a population you think that it matters the most in, and it won't matter if it didn't reach other groups at risk for incident HIV. So we'll now move into what I think is the most exciting topic in PrEP, so long-acting injectable PrEP, and specifically lenacapavir. So I know we've all heard a great deal about lenacapavir for PrEP and subcutaneous injection, but I just want to give an overview of where we are in the Gilead sponsored trials, the PURPOSE series. So far we have published and presented data from PURPOSE 1 and PURPOSE 2. And to remind us all, the populations in consideration there in PURPOSE 1, adolescent girls and young women in South Africa and Uganda. This was the only one of the PURPOSE trials that also looked at FTAF as a comparator arm. So there was subcutaneous lenacapavir every 6 months, oral FTAF or tenofovir alafenamide-based PrEP versus tenofovir disoproxil fumarate-based PrEP as FTDF. Individuals were randomized 2 to 1. We'll go to the incident infections a little bit later. PURPOSE 2 was MSM and other populations in a global setting, and this looked at LEN versus FTDF, 2 to 1. And I have italicized and grayed out the ongoing studies, PURPOSE 3 and PURPOSE 4, looking at adult women in the US, lenacapavir versus FTDF, and then people who inject drugs in the US. There's also a PURPOSE 5, but looking at very similar populations to PURPOSE 2 in Western Europe. And so what you can see when we go back to the incident HIV infections, and this is by the end of the randomized blinded phase, there were 77 in PURPOSE 1 in the oral PrEP arm and 12 in PURPOSE 2. And in terms of incident infections in the lenacapavir arm, we'll see they're very low. And so I'm going to focus on the 2, again, by the end of the randomized blinded phase in PURPOSE 1 and the 3 in PURPOSE 2. And really, we'll only talk about the 2 additional in PURPOSE 1 since published data and 1 in PURPOSE 2. So this is a series of 3 oral abstracts that looked at these individuals and then also resistance mutations. So first, as an update for PURPOSE 1, as a reminder, again, this was adolescent girls and young women, and the big takeaway was that lenacapavir for PrEP showed 100% efficacy. So this was very exciting. You'll notice that in the numbers I presented in the last table, the number was not 0, and that's because that was at the end of the primary analysis. There were 0 new infections, but by the end of the randomized blinded phase, there were 2 new infections in the lenacapavir arm. And that's what this first oral abstract focused on. So the first individual, so we looked at each of these, or they looked at each of these individuals in detail. So the first was participant C, a young woman who tested positive for chlamydia at week 52. HIV was diagnosed clinically on study at week 65 by typical serologic testing. And what I want us to look at is that graph of lenacapavir concentration. So what they did for each of these incident infections was, let's go back and see when the first time anybody had an RNA positive HIV test in a prior blood draw, and then also look at the lenacapavir concentrations over time. So what you can see is that participant C received on-time lenacapavir injections, and you can see that those concentrations were above the therapeutic range in all cases. The other thing you can see is that this was diagnosed really at week 65 with standard HIV serologic testing. So you can see that the antigen antibody test turned positive. The differentiation assay was indeterminate, but we did have qualitative and quantitative positivity. When they went back to week 52, there was a very, very low level viremia, 47. But prior to that, there wasn't much signal that there was a positive viral load or any positive HIV testing. What about participant D, the other breakthrough infection in PURPOSE 1? This was a young woman who had her last lenacapavir injection at week 26, then missed her week 52 injection, was transitioned to open label oral PrEP with FTDF at week 82. She was HIV negative at that time. And then we can see before we go to when HIV was diagnosed, you can see those lenacapavir concentrations really reflect that story. So they were therapeutic up until, or while she was getting injections. She wasn't getting injections, and you can see that that lenacapavir concentration plummeted quite rapidly. And so at the time of HIV diagnosis, her lenacapavir concentrations were subtherapeutic. And you can see that while she was on the open label FTDF is when she was diagnosed. This occurred in that time frame, not prior to her starting that. And her testing was positive, both by serologic testing and then by a pretty high viral load. So she was diagnosed after Len discontinuation while on open label oral PrEP about 16 months after her last lenacapavir injection. Okay, so now let's switch gears to PURPOSE 2. So again, we were talking about adolescent girls and young women, and now we are thinking about PrEP and MSM. Again, high efficacy. At the end of the pre-specified analysis, there were 2 new infections in the lenacapavir arm, and now we're focusing on 1 additional new infection in the lenacapavir arm at the end of the randomized blinded phase. And so this was the second of those 3 oral abstracts. So what you can see here is that this was a young person with a history of rectal chlamydia at screening and week 26 and rectal gonorrhea at week 26. When you look at that len concentration, you can see that again, it was mostly in range. So at the time of diagnosis, it was slightly below the IQ4, but well above that minimum concentration they've determined in PK for inhibition. And you can see that with that slight tick down where it kind of overlaps that line, but really looked mostly above the range. Received on-time injections. And at the time of diagnosis, this is interesting, right? So when we look, they were diagnosed at week 52 with a really high viral load. So really with acute HIV, a positive antigen antibody test, but negative differentiation assay and a viral load of 2 million. And that is despite all on-time injections and generally therapeutic lenacapavir concentrations with respect to PK data. Okay, so what about resistance? So in this third abstract, they looked at all 3 individuals that we just talked about and said, let's look at genotypes of participants in both studies who acquired HIV-1 and had an HIV viral load that was sufficiently high, 2 genotypes, so above 200. So the previous Purpose 2 acquisitions had been previously presented in both published data and at presentations. And so that's those first 2 Purpose 2 where you see the capsid mutation ends at 74D. What you can see here is that, remember, in one of the Purpose 1 participants, the viral load was pretty low, under 100, so they couldn't genotype the viral load in that individual, but you can see that there was N74D again, and then 2 other capsid mutations, Q67H and K70R. So of the 5 infections acquired on lenacapavir thus far in the Purpose studies, 3 have this capsid N74D. I think we'll need to learn more about these mutations, but just of note, and people have mentioned this in prior presentations, that in the Capella studies, so switching to lenacapavir as treatment, in those who had that N74D capsid mutation, people appear thus far to be able to resuppress on lenacapavir-based regimens with additional treatment agents, but with that capsid mutation. So just something to keep in mind. So our takeaways from the Purpose studies, one thing I didn't get to mention in the data that was presented, injection site reactions remained common in low grade. There were no further discontinuations related to those injection site reactions in either trial. In those who did acquire HIV on lenacapavir, the most commonly acquired resistance assay mutation was N74D, felt likely to be due to monotherapy rather than transmitted resistance. This is because they looked at database populations and really saw that this is not commonly present in wild-type virus. Lenacapavir remains highly efficacious as a PrEP option, though. So even though we don't know why the breakthroughs we presented, other than the one where that therapeutic drug level really dropped, we don't know why they happened. They had therapeutic drug levels and on-time injections, but remember, again, these were super rare. So of all the thousands of people in these studies, there were only 3 total in that I just presented, of 5 in general. And unlike long-acting cabotegravir, diagnoses were made pretty easily. So they were made in a timely manner with antigen antibody testing, and there wasn't that much retrospective looking back and realizing that people were kind of coming in and out of positivity. Okay, so now we'll flip again and bear with me through this investigational long-acting injectable study, and that's because there is some science and we're in macaques with SHIV instead of humans. The question that these investigators asked, they were looking at long-acting injectable PrEP with NRTTI, so islatravir implants, and looking at macaques with SHIV with M184V engineered. So the question that they asked was, can exposure to drug-resistant virus diminish PrEP efficacy? Prior macaque models had demonstrated efficacy of FTDF in SHIV with an M184V, although that efficacy diminished if there was also a K65R RT mutation. And so we know that in 2-drug therapy, it holds up pretty well against the M184V and transmitted virus. What about in 1-drug therapy? So this group has been testing islatravir implants for PrEP. This is a removable biodegradable implant in which preclinical macaque data has shown islatravir concentrations within safety parameters with high efficacy against repeated vaginal exposure to wild-type SHIV. And just as a reminder, HIV is an engineered virus that's simian virus with HIV-1 glycoprotein. So we know that M184V reduces HIV-1 susceptibilities to islatravir. And when I say we know, I mean I learned that during this oral abstract, and it seems important to me. So can these implants with islatravir protect macaques from rectal exposure to wild-type HIV, and does an M184V impact efficacy? So in this study, macaques with islatravir implants were exposed by twice-weekly rectal exposure to wild-type HIV versus M184V engineered HIV. And I'll also note at this time that there was another oral abstract in the same session that looked at another monthly NRTTI under investigation that still shares this issue of susceptibility to M184 HIV. So this is relevant beyond just this NRTTI. And they found overall that there was reduced efficacy of the islatravir implant with M184 HIV. So levels were therapeutic. There was complete protection by islatravir with wild-type HIV, but the majority were infected after exposure to M184 HIV. Other kind of details that are, I think, relevant, the removal of the implant did result in a rapid drop in islatravir levels, so we avoid the issue of a tail. But I think back to the main point, I think the question that raised for me and for everybody in the audience was what happens in HIV-1 and with transmitted non-engineered M184V virus. So knowing that we don't see much wild-type transmission of M184V because M184V virus is the less fit virus. So I think a lot of questions that are interesting, but I thought this really had some implications about what agents we continue to investigate as PrEP. All right, and with my last couple minutes, I will switch to STI prevention. So let's think about 4C-MenB vaccination for prevention of gonorrhea in MSM. And so David Spock in last ACC really set me up for this data. And so he had talked about briefly, if you recall, the idea that observational studies show that 4C-MenB, or the meningococcal B vaccine, may show cross-protection against gonorrhea. The previous trials have not borne out, most notably ANRS Doxyvac. But based on that observational data, vaccination programs in Europe have been implemented for those felt to be at high risk of gonorrhea acquisition. So this trial that was presented in an oral abstract was called GoGoVax, and it evaluated the efficacy of 4C-MenB against gonorrhea in MSM at high risk. The primary outcome was incidence of first and all episode gonorrhea 4 or more weeks after a 2-dose vaccination series. And the secondary outcomes were incidence of symptomatic or asymptomatic first episode gonorrhea and the incidence of first episode gonorrhea by infection site. This was randomized, double-blind, and in 7 Australian clinics. The population included was adult MSM with gonorrhea or syphilis in the last 18 months, either on PrEP and HIV negative or with HIV on therapy. They received those 2 doses of vaccine or placebo 2 months apart and were followed up every 3 months for 2 years, received STI testing at all 3 sites. Characteristics were pretty well balanced between the groups. You can see that, again, a large number had prior gonorrhea, so about 90%, 20% with prior syphilis, about 2/3 had more than 10 sexual partners, and a little over a third had no condom use with casual partners. I think the big disappointing outcome, though, was that 4C-MenB in this population was not effective in reducing gonorrhea incidence. And when they broke this down, there was no difference in groups for asymptomatic versus symptomatic infection, no difference based on site of infection, no difference based on number of sexual partners, condom use, group sex, or length of follow-up. And they didn't present this in their slides, but it did come up in the Q&A. There was also no difference in whether they were taking doxypep or not. So takeaways for meningococcal B vaccine for gonorrhea prevention. There was unfortunately no impact of vaccination in MSM at high risk of gonorrhea acquisition, consistent with prior studies. Unclear efficacy, though, in other populations. And so people keep bringing this up, right? The observational data does seem to imply that there would be some protection, and that might be in populations with lower incidence of gonorrhea. So women, adolescents, and what we're really getting at is there an impact of prior gonorrhea infection on protection from future infection that we're not able to see in these populations where 90% or more may have had prior gonorrhea. So there is some randomized clinical data that is in the pipeline for those populations. And I think other things that were brought up that I thought were interesting to explore further were the impact of a 3rd dose. And then I think some of the naysayers were thinking that maybe this vaccine is all wrong and we should be focusing on the difference between mucosal versus systemic immunity. So in conclusion, I know we kind of went all over the place here, but as a reminder, on-demand and oral and daily oral PrEP remain highly effective options for HIV prevention, though inequity in access remains a barrier. Lenacapavir PrEP remains a robust option with few breakthrough infections. Single-agent NRTTIs, such as long-acting injectable PrEP, may be vulnerable to common mutations, such as an M184V, and in men who have sex with men at high risk for gonorrhea acquisition, meningococcal B vaccination was not effective in reducing gonorrhea incidence. So with that, I will stop my share so that I can pass it along to Jehan to talk about treatment.
Raaka, thank you. That was amazing, as always. And so I will now talk about treatment. I have no disclosures, and I'm going to start off with discussion about something called non-canonical mutations, give a few updates on rilpivirine injections, and then last finish up with just a few new medications in the pipeline. So non-canonical mutations. There was a themed discussion about these 4 abstracts, one about mutations in envelope, nucleocapsid mutations leading to virologic failure of INSTI-based antiretroviral regimens, more non-canonical mutations in TLD treated people with HIV, and then characterizing mutations outside the integrase gene in people with, or enzyme in people with HIV with dolutegravir virologic failure. So I went to this themed discussion and was trying to look up what a non-canonical mutation was. And so this was new for me. I think it might have some implications, and so I wanted to share with everyone. So as a bit of background, non-canonical mutations are HIV drug resistance mutations that occur outside the drug target site. And so they have found non-canonical resistance mechanisms for INSTIs, PIs, NNRTIs, and NRTIs. There's a really nice article that I have referenced here that's just actually about 5 or 6 pages that really kind of takes one through what these are. So what impact might they have? They might restore viral fitness caused by drug resistance mutations in those target sites, enhance resistance when they occur with RAMs at the drug target site, independently cause resistance even in the absence of resistance at the target site, or prime the emergence of resistance variants. So maybe setting the stage for mutations to emerge. And the clinical relevance of this is unknown. As I mentioned, I was doing some Googling and researching during this themed session, and I thought it would be helpful to share this slide that David Spock made. As a reminder, the HIV-1 genome contains 9 genes that encode 15 viral proteins. Typically, I recall from early classes about the GAG, POL, and envelope genes. And as you might be aware already, that really we focus on POL, or the POL gene, with the protease, reverse transcriptase, and integrase medications or drug target sites. Now, today I'm going to talk about the nucleocapsid mutations that arise in the GAG or from the GAG gene, and then some mutations in envelope. And so this first abstract showed that mutations in envelope might be a gateway for acquisition of INSTI resistance. As I might have mentioned, there's prior evidence that HIV-1 develops resistance to dolutegravir by initially and sequentially acquiring mutations in envelope, nucleocapsid, and in some cases then integrase. And so here, the authors did serial passage over 2 years of multiple HIV isolates in peripheral blood mononuclear cells in the presence of dolutegravir and raltegravir. Now, the HIV that was exposed to raltegravir developed canonical INSTI-RAMs, or sort of the usual INSTI resistance that we saw. But in contrast, the envelope mutation was a gateway for stepwise acquisition of higher level INSTI resistance, so different pathway. Then they talked about nucleocapsid mutations in virologic failure of INSTI-based regimens, and of 145 people with HIV with virologic failure from an INSTI-based regimen, they found that 75% of those individuals had nucleocapsid sequences. Then of those sequences that they could look, they found mutations in 12 people with HIV, but none had INSTI resistance. So people failed INSTI-based regimen, and they found nucleocapsid mutations, but no INSTI resistance. Then They looked at non-canonical mutations in TLD or tenofovir DF lamivudine dolutegravir single tablet regimen used widely in the world, treated people with HIV with unexplained virologic failure. They were able to get sequencing among 17 people with HIV with virologic failure, which they defined as greater than 400 copies per mil, on TLD in the UTRA study, which was in South Africa. And of these individuals in the nucleocapsid, they found the emergence of an N27S and M46L mutation, which was associated with low-level INSTI resistance. And then in envelope, they found the emergence of a T641I, which is associated with low-level INSTI resistance in subtype C only. And then last in this theme discussion, they characterized mutations outside of integrase in people with HIV with dolutegravir failure, and they were able to do whole genome sequencing of 33 people with HIV in Cameroon who had virologic failure. About 26% of those individuals had at least one non-canonical mutation in GAG, and then 100% had a mutation in envelope. None of the 12 known non-canonical major mutations observed were significantly associated with INSTI resistance, which is good. But 17 novel mutations identified, 3 in GAG, 14 in envelope, in people with HIV with INSTI resistance, and 2 were identified in people with HIV without INSTI resistance. So again, if you're scratching your head, I too was scratching my head. I continued to scratch my head. This is, to me, a bit of a confusing new world. And I think, again, what I wanted to do is introduce that this is a thing and that it might have an impact on INSTI or on virologic failure, on individuals failing on an INSTI-based regimen, even if we don't find INSTI RAMs. And I think we've all been there before where people appear to be failing, get a genotype, there's nothing there. They're taking their meds and you're wondering, what could be going on? Again, classically, people are not, or not classically, but typically people are not adherent. But in this case, maybe there's some non-canonical mutations. So that was just a brief introduction, and I think we'll see more in the future and maybe have a better sense of if there is clinical relevance or not. So next, changing gears to Cabril-Pivirine, I want to talk about 3 categories: pregnancy, elevated BMI, and then an abstract regarding virologic failure. So one of the 2 pregnancy abstracts that I found interesting was this one, looking at viral kinetics. So I think we know that there's some data regarding safety, efficacy, and outcomes of Cabril in pregnancy. They are emerging, but we need more. And most recently, we have data from last year's CROI of a multi-center retrospective review of 23 pregnant women who were prescribed long-acting Cabril injections between 3 years, and outcomes were favorable. So then this group, the same individual, or at least one of the same individuals, did a case series of 4 people initiating Cabril while pregnant and viremic, of 3 with paired viral loads. The median decay slope was 1.6 logs per week. So basically, this is, again, just looking at viral load kinetics after starting Cabril-Pivirine during pregnancy while viremic. You'll see here the regimens of these individuals, the gestational week that they were switched to Cabril while viremic. And we found that essentially, or not we, they found that at essentially 1 week, the viral load dropped by 1.5 logs. For context, typically with a dolutegravir-based regimen, we'll see a 2 log drop at 1 week. So I thought this was pretty darn good for a injection-based regimen. And so again, we're just learning more and more about viral kinetics. This is specific to pregnancy. Next, we got some more data on Q8-week dosing in pregnancy. As a reminder, rilpivirine concentrations may drop in pregnancy. And if Cabril is used in pregnancy, most would use Q4-week dosing. I certainly would, as there are concerns that rilpivirine concentrations may drop below the protein-adjusted EC95. And here, there was a multi-center retrospective chart review of pregnant people with HIV prescribed Q8-week Cabril-Pivirine, and they wanted to describe the virologic, obstetric, and perinatal outcomes. 15 people met the inclusion criteria, all conceived while on Q8-week Cabril-Pivirine, so the medication had already been in their system. I don't recall how long they had been on it, but it was in their system. they were doing Q8 weeks, and all had viral suppression throughout their pregnancy. I included the median number of viral loads checked because that is something that I know I think about when I'm taking care of someone with pregnancy, and I think a lot of my colleagues do, where we're wondering how often to check a viral load. In this cohort, they checked it 3 times, but the IQR was 3 and 5. So although promising, more safety and drug level data in Q8 week dosing are needed, and I will certainly continue to do Q4 week dosing in pregnancy until we get more data. Then switching gears regarding elevated BMI, I think most of us know that we have a paucity of data regarding cabrilpivirine efficacy in peoples with BMIs greater than 40. And in fact, traditionally, there hasn't been much data, save for a couple of individuals who have a BMI greater than 40. So I was pleased to see this, which was from the OPERA cohort, looking at people who are virally suppressed, starting cabrilpivirine. And here you'll see in the blue, 4,600 people started cabrilpivirine. And then they categorize those individuals as not obese with a BMI less than 30, high BMI, 30 to 40, and a very high BMI of greater than 40. And there were 201 individuals in this cohort who had a very high BMI. That's the largest to date of any study that has elevated BMIs greater than 40. The median BMI was 44 with an IQR of 41 to 48. And on the right, you'll see the results. In the light orange is the very high BMI. And you'll see in the very high BMI, there was no difference between BMIs as far as viral suppression at the last viral load check. And again, no real difference here with if all viral loads were less than 50. Notably, here in the bottom is confirmed virologic failure. 21 people in the non-obese BMI, 18 people in the high BMI, and 1 person in the very high BMI group experienced virologic failure, all 1 to 2% total. Everybody failed within 7 to 9 months, or at least the median failure was 7 to 9 months, which is consistent with what we've seen in the past. And so takeaway is that viral suppression was maintained regardless of BMI at initiation, including in individuals with a BMI greater than 40. And then the last of the Cabril studies that I'll share is virologic failure from an Italian cohort, retrospective observational cohort of actually 2,000 people with HIV who started cabrilpivirine in 22 Italian clinical centers. 45 had virologic failure, so for a virologic failure rate of 2.1%. The persons who had virologic failure were quite treatment experienced. Median ART duration prior to start was about 12 years, and the median BMI prior to start was 25. And you'll see here the IQR. So people had a BMI generally less than 30. The virologic outcomes of those persons with virologic failure was that the median duration to failure was 7 months, very similar to, again, what we just saw and what we see in most studies. Of those 45 individuals who had failure, 87% were virally suppressed prior to the switch. So I think that's a lot. 87% of people switched to cabrilpivirine, of the virologic failures, 87% were actually virally suppressed, switching and then developing virologic failure. None had more than one of the following risk factors: subtype A6, BMI greater than 30, or pre-existing rilpivirine RAMs. So again, these were not individuals who had lots of risk factors for failure. 43 had genotypes at failure available, and not surprisingly, 75% had NNRTI resistance or INSTI resistance, consistent with what we've seen in the past, that if you fail on cabrilpivirine, you tend to accrue and fail with many mutations. 42 out of 45 changed therapy after virologic failure, and of those, 93% resuppressed. And last, I just want to show this slide of new medications in the pipeline and share one abstract that we talked about. I wanted to include or make this table for everyone because at CROI, I was a bit overwhelmed with the number of new regimens, trying to figure out why said medication is being paired with another one. I would also encourage you, if you are curious, to look at the pharmaceutical companies to figure out why certain things are being paired with others. And here are some daily PO regimens there. We had some study updates from weekly PO regimens, and then long-acting BNAb-containing regimens, which they still continue to be studying, and we'll see if that pans out. But the one I wanted to sort of focus on today was BIC combined with LEN oral as a daily regimen in Artistry 1 and 2. I'm focusing on Artistry 1 here, which was a phase 3 randomized open label trial of efficacy and safety of switch from a very complex regimen to single tablet Bic/Len every day. These were about 550 people with HIV randomized 2-to-1 to Bic/Len versus a continued complex regimen. The median ART treatment duration was 28 years. So again, a very highly treatment experienced group of individuals. They tended to be older. 81% had another comorbidity. So again, other medical problems. Median of 3 ARV tablets per day. Here you'll see on the right is sort of the regimens that people were on. They found viral suppression was high and non-inferior to the complex regimen, and no participant had emergent resistance. Drug-related adverse effects were more frequent, but satisfaction was higher in the Bic/Len arm. I do want to pause and just mention that I found myself again during the study wondering, why are we putting people on Bic/Len, or who might I put on Bic/Len? And I think I would be hesitant to put somebody on Bic/Len from a stewardship perspective, because I would like to save lenacapavir and the capsid inhibitors for the long-acting regimens, especially for individuals who might have difficulty taking pills or who don't have other regimens. So I kind of want to save Len for that group and not population-wide sort of start occurring capsid mutations. However, I think in a patient population similar to the one they studied here, who let's say is an older person with HIV who's had HIV for a long time, been through many medications, maybe doesn't have a lot of options, or has polypharmacy and has lots of ART, perhaps this regimen might be it for them, where we've paired lenacapavir with a really high barrier to resistance, high potency medication like bictegravir with few adverse effects, Bic on its own has few adverse effects. And so I think that is the patient population in whom I might use this when the time comes. But otherwise, I'm not going to be reaching for it as soon as it's FDA approved, whenever that may be. So in conclusion, non-canonical mutations, or again, drug resistance mutations occurring outside the drug target site may have an impact on INSTI susceptibility, but more clinical data are needed. In observational cohorts of pregnant individuals on Cabril, viral decay was rapid, and more data are needed on Q8-week dosing. For now, continue with Q4-week dosing while pregnant. In an observational cohort of people with HIV on Cabril, viral suppression was high, including in about 200 people with HIV with a BMI greater than 40. And as always, there are many new medications in the pipeline. So now I'm going to hand it over to Jimmy.
Thanks, Jehan. I am gonna share. Cool. There we go. All right. So it's really good to talk to you all about co-occurring conditions from CROI this year. I have no conflicts of interest or relationships to disclose, and just like everyone else, it'll be a whirlwind of a lot of different topics. I'll be focusing on Hep B reactivation and new infection in the context of tenofovir-sparing regimens, management of disseminated tuberculosis, and weight loss and GLP-1 drugs. I'll provide a brief background for each section, present the abstracts, and then do a general takeaway at the end of each section. So we'll start with Hep B updates. So guidelines currently recommend Hep B treatment for all people with HIV who have Hep B, given faster progression and higher burden of liver-related diseases in folks with HIV compared to the general population. And concurrent with this, there's increasing use of ART without Hep B activity, including the long-acting injectable Cabril that we've been talking about, 2 drug therapies, and oftentimes people who are older are coming off of tenofovir due to co-occurring conditions that tenofovir may not be good for. Notably, Hep B reactivation has been described with ART regimens that only have lamivudine or emtricitabine, such as with dolutegravir, lamivudine. Coming into CROI, it was known that Hep B reactivation risk was low, but varied in those with prior infection after switching off of Hep B active ART. In the US, which is a low burden setting, this occurs about 1 to 2% going up to about 10% in higher burden settings such as Cameroon, occurring at a median of about 9 months after switch, ranging between 3 weeks to 14 months in some of these series and studies. The risk is highest in folks with prior known Hep B surface antigen, up to 20% in one series, and lowest in those without prior known Hep B surface antigen positivity, about 1 to 2% in that same series. So at CROI this year, there were a few abstracts addressing more specific questions related to Hep B reactivation and infection. Although some of these had been addressed in earlier studies, most were fairly small with less than 60 people or less in case studies. So these are the questions that were addressed in a little bit more detail. And for the first one, in an oral abstract, Hazer and colleagues looked at rates of Hep B reactivation and a new infection in folks with HIV switching off tenofovir-based ART in the Phoenix cohort, which is a large US-based cohort of adult folks with HIV in routine clinical care. Folks with HIV were included if they were prescribed tenofovir-sparing ART for at least 3 months. They had Hep B surface antigen and surface antibody results available before the switch, and there were no prior surface antigen positivity or Hep B viremia. In the about 5,800 folks with HIV enrolled and followed over a median of about 3.5 years, 80% switched to partially active Hep B regimens with either lamivudine or emtricitabine still present, while 20% switched to fully Hep B inactive ART without tenofovir. Notably, overall, Hep B reactivation or new infection was rare, occurring about 0.4%, similar to earlier studies in low-burden Hep B areas. Notably, most of these were considered new infections occurring in those without surface antibody, though some new infections did occur in those with detectable surface antibody. Overall, there's a greater percentage of reactivation occurring in those off of tenofovir, and the two definite Hep B reactivations occurred despite pre-switch surface antibody detectability. Overall, LFT elevation, which greater than 100, which they defined as a hepatic flare, was rare, occurring in about 14% of those with reactivation or new infection. And overall, of those 21 who had new infection or reactivation, about a quarter switched back to tenofovir-based regimens. They then looked at different predictors for reactivation or new infection in multivariable logistic regression, and the strongest predictors in that was a CD4 less than 200 at switch and Black or Asian race. Notably, notably about 30% did not have pre-switch full Hep B serologies, meaning they didn't necessarily have standard screening or monitoring peri-switch with full Hep B serologies. A similar abstract from Diederich and colleagues examined the prevalence of Hep B co-infection in folks with HIV starting CAB-RIL in the OPERA cohort. In about 5,200 participants, over 90% were virally suppressed at baseline when they switched over to CAB-RIL. 14% had evidence of lifetime Hep B infection. And of these, 85% had prior Hep B with immunity, 10% had prior Hep B without immunity, and 5% had active Hep B as defined by these Hep B serologies. It's not clear, notably, if this Hep B surface antigen positivity was the latest Hep B surface with the latest Hep B serologies or ever in the past. But across these Hep B serology groups, few Hep B lab checks occurred at the time of start or after starting CAB-RIL, as noted here. And similar to earlier studies, Hep B reactivation was rare, occurring in less than 1 to 3%, depending on the group of individuals with prior infection, and unsurprisingly, frequently in those defined as having active Hep B, occurring greater than 50% of the time. And then reactivation occurred greater than 2 years for those who were immune, about 3 to 6 months with prior infection without immunity, and then within about 3 to 4 months in those with active Hep B. Over half of individuals, interestingly, with Hep B reactivation continued on CAB-RIL, with most adding an anti-Hep B agent. And almost all people with prior or active Hep B remained HIV virally suppressed during the follow-up time, and they did not have any data on hepatic flares. So Overall, these CROI abstracts are consistent with prior data suggesting that Hep B reactivation is rare in folks with HIV, with evidence of prior Hep B infection, and can occur in those with or without Hep B surface antibody positivity. Hep B reactivation or new infection in surface antibody positivity may reflect waning Hep B immunity, or depending on the timing of grabbing those labs, represent new infection that just so happened to be detected. Hep B reactivation risk also appears to be higher in those with known Hep B surface antigen positivity, similar to earlier studies. Hepatic flare is rare but may be serious, typically resolving with restarting Hep B active therapy, and full Hep B serologies before ART switch, especially close to the switch, is helpful to characterize reactivation or new infection risk and identify opportunities for immunization. Furthermore, routine monitoring of liver and Hep B markers should be helpful to catch reactivation and new infection based off these data. Moving on to updates for tuberculosis. As many of you all know, disseminated TB occurs frequently in folks with HIV and has high morbidity and mortality, especially in those with low CD4 counts. Mortality can be up to 25 to 30% globally. As a result, there's a need for new management strategies to improve outcomes. There were 2 oral abstracts presented at CROI this year addressing the question of whether intensification of TB therapy might be helpful, or whether adding additional steroids may be helpful. For intensification of TB therapy, there are some reports that there may be low plasma concentrations of standard TB drugs, meaning HRZE, at standard doses. And the rationale for adjunctive steroids comes from potential for improved outcomes in TB meningitis and other respiratory infections, and the detection of high levels of markers for innate activation and chemotaxis. Looking first at the Datura study, in this oral abstract, the Datura trial occurred this was a multinational phase 3 trial. Investigators evaluated whether intensive TB therapy was better for mortality compared to standard TB therapy. Included patients were over the age of 15, had low CD4 counts, and hospitalized with newly diagnosed TB based off of expert urine lamb or chest x-ray consistent with active TB. Individuals were excluded if they had recent TB therapy, CNS symptoms, pericarditis, any contraindications for steroids, rifampin-resistant tuberculosis, pregnant or breastfeeding, or had end organ dysfunction, whether in the kidneys or in the liver. Individuals were randomized 1-to-1 to standard therapy, which is seen here, or intensive therapy, which had higher doses of INH, rifampin, added corticosteroids, and albendazole. These occurred in the first 8 weeks. All individuals got ART starting at week 2, and then after the initial 8 weeks phase, all individuals were put on standard dose HRZE for the remaining 16 weeks. And here are the results. So they enrolled 908 individuals with 50% in each arm, and found that intensifying the initial phase of tuberculosis therapy did not decrease mortality for severely immunocompromised folks with HIV at 48 weeks. They also looked at this by pre-specified CD4 cutoffs, as you can see there, and also within the 802 individuals with disseminated TB, and there were no differences within those subgroups. Mortality was also similar at all key time points, as you can see there, up to week 48. Higher dosed rifampin and INH resulted in higher Cmax and AUC as expected, and overall grade 3 to 4 adverse events were not significantly different between the 2 arms. There was a greater risk of drug-induced liver injury and hyperglycemia and diabetes, but less TB iris in the intervention arm compared to the standard treatment arm. Overall, still a very high mortality with over 25% in the overall study at week 48, despite these interventions. In this oral abstract, New Strat TB, they looked at adjunctive steroids specifically for this oral abstract, but the New Strat TB trial overall looked at was a 2x2 factorial design for whether intensified TB treatment and prednisone may help disseminated TB mortality rates. The 2x2 factorial design was for the first 14 days, standard versus intensive treatment, and prednisone versus placebo. And after the first 14 days, everyone got standard TB treatment through 6 months. Intensified TB treatment included HRZE with higher rifampin dose plus levofloxacin, and prednisone was dosed at 1.5 mg per kg each day. Inclusion and exclusion criteria are shown here, with those being very similar to those of the Datura trial. And intensification data were presented at CROI 2025 and was ended early because of higher mortality at 2 weeks in the intensification arm compared to the standard treatment arm. The prednisone evaluation was continued after the ending of the intensification evaluation. And so at CROI 2026, the authors presented the adjunctive steroid data, and unfortunately, the high-level punchline is that there's no significant difference in mortality when on prednisone. As you can see here, the 700 participants enrolled all had fairly low baseline CD4, and most did not have viral suppression at enrollment. Prednisone didn't appear to reduce mortality at 14 days or at 12 weeks, but was well tolerated without significant difference in adverse effects between the two arms. The figure here shows mortality broken down by group, with the highest mortality in the intensified placebo arm and the lowest in the standard treatment arm with prednisone. But which was fairly similar to the standard treatment without prednisone. Steroids may have rescued some of the effects of intensification, but there was no statistically significant interaction by intervention at 14 days or 12 weeks, based off what the authors had suggested there. So disappointingly, intensification of TB medications does not improve and possibly worsens mortality and toxicities. Corticosteroids appear well tolerated but did not improve mortality for folks with disseminated TB. And in the Q&A session, they discussed potentially where the work might go. They talked about needing to look at other causes of death and alternate management strategies in folks with disseminated TB who also have HIV. So finishing up here, we'll talk about weight loss and GLP-1s. As many of you know, folks with HIV face higher levels of weight gain, cardiometabolic and co-occurring conditions than in the general population, especially as folks with HIV age, and these often occur earlier in folks with HIV. GLP-1 drugs and other incretin analogs like tirzepatide are highly efficacious for weight loss and diabetes, and evidence is accumulating for management of using these to manage other conditions such as sleep apnea, heart failure, steatotic liver disease, and even substance use. Lifestyle modifications are still important given the risks of sarcopenia and weight rebound if these agents are stopped. And often these studies don't specifically look at folks with HIV or exclude them from the trial, so more data are needed for effectiveness and safety in folks with HIV. So I'm just going to go through a lightning round of abstracts looking at semaglutide, tirzepatide, and physical activity for your future perusal, and a quick summary of these. So looking at semaglutide, in the CNIX cohort, semaglutide started for diabetes or weight loss was associated with reductions in liver fibrosis in those with likely steatotic liver disease in those with metabolic associated steatotic liver disease. Also decreases in tobacco use in those who use cigarettes, and there is that signal and association that potentially GLP-1s may worsen depression, and this wasn't borne out within this abstract in CNIX. Additionally, in a phase 2 randomized controlled trial, folks with HIV who had lipohypertrophy were randomized to 32 weeks of semaglutide or placebo, and they did not find significant changes in subclinical vascular function or plaque, but notably did find improvements in lipids, abdominal fat, weight, BMI, and blood pressure, which the authors suggest that overall there may need to be longer-term follow-up in order to see changes in some of these vascular function or plaque. Looking at tirzepatide, at the UCSD Owen Clinic, tirzepatide was associated with reduced weight, about 14% reduction, BMI, about 5 points, systolic blood pressure, A1C, and 10-year ASCVD risk score dropping by about 3% overall over the 12 months that they followed up. They had 61 folks who got started on tirzepatide, 22 with diabetes and 39 without, and they overall found greater weight loss in those without diabetes. And then interestingly, about a quarter stopped tirzepatide in the first year, but mostly due to insurance and supply related challenges, more so than side effects and lack of efficacy. Again, in the Phoenix cohort, folks with HIV on tirzepatide were compared to those who were taking semaglutide, and overall tirzepatide was associated with more body weight loss and a greater decrease in A1C compared to semaglutide. And this was borne out across subgroup analyses by sex, BMI, and diabetes status. And finally, the GYM study here, looking at a little bit at physical activity. This was a 48-week home-based intervention, randomized controlled trial, randomizing individuals to 48 weeks of 4 times a week, 40-minute guided sessions of exercise, as you can see here, versus just a recommendation of getting at least 150 minutes of activity per week. And there was evidence of improving muscle strength and mass in those older individuals with HIV with sarcopenia. So takeaways for this section, semaglutide and tirzepatide appeared generally safe and beneficial for managing diabetes, weight, and a variety of other conditions in folks with HIV. And then that guided physical activity is helpful for improving muscle strength and mass in older folks with HIV with sarcopenia. This could perhaps be applicable for those on these GLP-1 inhibitors, sorry, not inhibitors, agonists, which may cause some sarcopenia with the weight loss. So in conclusion, Hep B reactivation and flare are rare in folks with HIV in low burden settings, but risk really varies based off of prior Hep B serologies and history. And as a result of that, full Hep B serologies should be obtained near switch when folks are coming off of Hep B active ART to determine reactivation and infection risk and opportunities for vaccination. After the switch, folks should be monitored for their liver and Hep B markers, especially if they're at higher risk. Treatment for intensified tuberculosis therapy or steroids for disseminated TB does not improve mortality, and these new GLP-1 and incretin analogs appear generally safe and helpful for managing multiple conditions in people with HIV.
Great. Thank you, Jimmy, Jehan, and Raaka, so much for really excellent talks on a lot of information. We've got about 3 minutes, and there are a few questions and comments that have come into the Q&A box. I'll keep an eye on that. Jehan, I wonder if you want to just briefly address the conversation about the dose of bictegravir.
I responded in the chat, but I'm happy to just answer again that Rod had posed that question. That was actually a question that came up about why in Biclen was it 75 milligrams versus 50 milligrams in the BIC-TAF FTC co-formulation. And Chloe Orkin quickly responded that it was due to sort of my understanding was how it was just due to PK studies, and that's what they realized they needed.
Great, thank you. Linda, I see your question. I'm not quite sure what this refers to, so I'm sorry. It says, remind me regarding vaccination opportunities for HIV patients. I'm just not sure what that refers to. I apologize. Any other questions? Feel free to clarify if you'd like directly to the presentations we just heard from CROI. An anonymous attendee asks, does anyone have any information on running genotypes with a viral load under 500?
I mean, I can share my clinical experience that, it's interesting. Sometimes I have patients with a viral load greater than 500 and they cannot amplify it. And then I have had patients with a viral load of 300 and they can. So I think it depends. But I'm not sure if that answers your question. I think oftentimes I'll order the genotype and just see what happens.
Great, thank you. And I see, Jimmy, you are typing with Linda about that question. So I think mostly hearing thank yous from people. Thank you all for really excellent talks and appreciate that whirlwind and very helpful review of all the info at CROI. So thank you all so much. And thank you to all the attendees for coming today. I hope you have a wonderful rest of your day. Take care.
Thanks so much.